Dr. Sohan Perera from Sri Lanka will speak on the topic total ureteral avulsion in URS, how to tackle and preventive strategies. Over to you, Dr. Sohan.
Dear chairpersons, I would like to thank the organizing committee for giving me this opportunity. Let me talk about total ureteric avulsion in URS. Well, incidence-wise, it's less than 1%, and now the current database says it's about 0.3%, so it's not a major problem, but during our career, everybody would have come across this, and sweating problems, right. So 2 reasons. One is the patient, other thing is the instrument. Patient, there may be a narrow ureter, or there may be a stricture. Ureteroscope, the width of the ureteroscope, I'll go through that later, but if the ureteroscope is too large for the ureter, it will not accommodate the ureter, so pushing can cause damage to the ureter, or if there had been some inflammation in the ureter during the procedure, it can get avulsed. So ureter, which is about 3 to 4 millimeters, length is about 20 to 30. So how does it happen? While inserting the scope, we all know the narrowest part is the ureteric orifice, close to the bladder. So when we are trying to navigate the ureteroscope, we can push and cause damage. And then extracting calculus, especially Domia basket, one of the dangerous instruments we have, pull it, then we damage the ureter. And if you have we have managed to put the scope up somehow, when you are pulling it down, again there's a risk of damaging the ureter. So those are the 3 ways that it can damage. So it can damage the lower end, upper end, or both ends, which is called scabbard. And then the mucosa will come out like a sock. The ureteroscopes ranges from 7 to 12 French. Now the biggest problem we encounter is we have small scopes and larger scopes. This part of the world, we use the smaller scope, which is about 6 French, and it bends, it breaks. So we are left out with the 10 French one. And we try to navigate that with the 10 French one, which all would have encountered in this part of the world. And then we don't know how to navigate that. So prevention, mainly 2 advices: don't push hard or don't pull hard. Push, the ureter can get avulsed from the low end. If there's a stricture, it can get avulsed, or if there is inflammation, it can get damaged. Pulling, especially the stones, if you pull hard, then the problems come. $1 million question, how to know the force? You need to lose some hair, you need to have some gray hair to encounter that, because nobody can teach that. It comes with experience, but pushing, yes, we all know we give some force when we are putting the ureteroscope. So to know the force to give, it takes some time. So when only you know, right, this is the time where we have to give up, put a guide wire, put a stent, and come out. When you are pulling, if it is too hard, it's not coming out, stop it there, fragment the stone again, and prevent the damage. Detection, most of the time you will see that there is a problem, there will be bleeding, mucosa will be not there. If you are not sure, you can do a retrograde study. And if you are not sure, we can leave a stent and come later on tackle. Surgeons are surgeons. Usually they don't want to believe what has happened, so sometimes people tend to leave a stent and come, and then later on go and tackle the problem. You can do a CTI view and then take it from there. So management, if you have detected that there is an injury, it's evident, then you can do low end, you can do a ureteroneocystostomy where we implant the ureter, or do a Boari flap. Upper end, pyloureterostomy, it is there, but the mouth database says that the long-term outcome of pyloureterostomy is not that good. So they prefer either a Boari flap, long Boari flap, ileal ureter, or auto transplantation. Then problem is both ends. Ideally, we can do a pyloureterostomy, ureteroneostomy, and great omental investment, because now both ends have got dislodged. So there is a problem with the vascular supply, so we have to have some coverage from the omentum. Or best thing would be to do a ureteric reconstruction with tapered bowel. Thank you.